Transitioning to the next session, I would like to invite Dr. Tirthankar M., Consultant Physician Diabetologist and Professor of Medicine at KIMS Hospital, Bengaluru, and Dr. Indrashish Mukherjee, Consultant Physician and Diabetologist, Lucknow. Welcome, sir.
Good morning. I welcome Dr. M.V. Rama Rao. He is a consultant endocrinologist and diabetologist practicing at Nellore. He has done his MBBS, MD and DM and is the founder and director of EndoAccad Foundation. He is also a EC member of the ESI. So he will be speaking on the newer premixed insulins in this glycemic havoc. Over to you, Dr. Rama Mohan.
Yeah, good morning everybody. Thank you, Chair, for the introduction. And I would like to congratulate Dr. Srinivas Murthy sir for his wonderful ILET conference. And today's my topic is on new generation of insulin, promising solution to glycemic havoc in India. This is a corporate talk. We know that in future it is going to be, India is going to be a diabetic capital. Everybody knows about epidemiology, and we are seeing young diabetes patients nowadays. And the challenges in India are we eat more carbs, so we eat more rice. Our prandial sugars are very high always, and we don't do exercise. We have more belly fat, so we are obese. Then the glycemic response is poor. Southeast Asian, so our genes are very weak. So we have a multifactorial defects in our system in diabetes patients and control. Then we know that half of the patients will be on prandial phase and half of maybe 12 hours will be in a fasting phase. So PPG is half of the control of diabetes by PPG, and we know that we eat more. We tend to take tablets in the morning and night. We tend to have 3 or more maybe snacks, and snacking is also there. So our prandial sugars are high in most of our patients, and it is very difficult to mimic natural non-diabetic sugars, how they control with a good glycemic maybe control. Maybe for example, you take a non-diabetic patient, he has a good insulin surge in it. So every time he eats, he has a insulin production. Then the graph flattens after insulin production from the pancreas after he takes food. But in diabetics, it is very difficult to mimic the natural physiology, and we tend to have a very good control is very difficult in most of our patients, very difficult. So inadequate control with first generation insulins. Starting an insulin is also a big headache for every person in OPD. So if you start insulin, if you start discussion about insulins in most of our patients, you tend to be in a back foot, and patient tells you that, sir, please give me some time. This time I'm not ready. So insulin, I have a fear of needles. So this discussion starts like this. So to decrease it, we start with a basal insulin generally. So 1 poke per day we start, then we tend to mix with premix insulin afterwards. So with this 1 poke of insulin is like basal insulin also, we are not happy 100%. Only 30% of the patients have good HbA1c reduction. Others have a bad reduction because it is not a proper answer for their glycemia. And then targeting both fasting and PP is very, very important. Mainly, first we tend to treat the fasting first, then we move to the postprandial. But only in targeting fasting also we are not getting good results. So the aim of the control is both fasting, postprandial should be controlled to have a good HbA1c reduction. That is the aim of, this is the ideal situation where we should be targeting. Total control, so we have many premix insulins. See, among the premix insulin, we had to choose a new one where we have a very good aspart and also very good long-acting degludec. So we know that degludec is a long-acting insulin, and this co-formulation is successful for last maybe 5 to 6 years, and we have seen most of our patients doing good with this premix insulin. So it's a simpler insulin regimen, fewer injections are needed, and greater flexibility in dosing time is also there, and a fixed ratio co-formulations. So now we'll be seeing how good it is affecting. So Ryzodeg in action, it is a degludec of 70% and aspart of 30%. So in subcutaneous depot, you can see that IASP has a hexamer, degludec has a dihexamer, and slowly degludec is released and IASP is released very fastly. That means that we have a basal insulin and we have a fast acting, ultra fast acting insulin also in the same way. And so key attributions are, it is very good efficacious, it is very safe, the quality of life in most of our patients with Ryzodeg is good, and it is very flexible in dosing. And efficacy, as I told you, the HbA1c reduction is excellent, more than 1.8% in most of the clinical trials and post-marketing and post-trials it has shown. And compared to OAD treat patients, if you add insulin, we have a very good HbA1c reduction. And significant PPG reduction is also there because we are using a long-acting insulin, which is degludec. We have a very good fasting reduction. Then we have a very good post-breakfast reduction because we added an IDEG aspart in this. Then compared to other things, we have a low hypoglycemia in comparative studies. You can see that if you add only basal insulin and if you take premix insulin, the hypoglycemia is less in because of the maybe you are giving a low basal insulin compared to the full single dose of basal insulin. And higher levels of convenience is that mainly different situations where the patient want to take more food in the snack, for example, in the breakfast, in the lunch, you can change to giving this insulin in the morning or in the afternoon also, depending on the how amount of carbohydrates is taking. And also there is improved quality of life with Ryzodeg. See, the starting point is very difficult in any place to start insulin to your patient. If they are comfortable, if they are agree with you, and then you can see the quality of life improves. They are very happy. They gain weight. Their sugars are under control, and the same thing happening with Ryzodeg also. And higher percentage of patient preferences Ryzodeg is seen in the post trials compared to other insulins. And flexibility with Ryzodeg, you can see meal time and meal relaxed flexibility is always there. Initiate 10 units of Ryzodeg with most carbohydrate heavy meal of the day. You can do that. And cost effectiveness as also Ryzodeg, they come down with their pricing also. Now it is coming around 900 to 1000 rupees only per 400 units. So initiation, how to initiate? Start 10 units of Ryzodeg OD with most heavy carbohydrate meal. Weekly titration is needed. And if you want to give BD also, you can give Ryzodeg. And mainly in special populations compared to elderly, then renal and hepatic, religious fasting in Ramadan trial, and adult type 1 diabetes also, this works very well. And they have a very good, the good news about all the products from Novo is that they have a very robust scientific data behind their molecules. So coming to the glance of Ryzodeg, you can see effective in both fasting and postprandial, effective in HbA1c reduction, low risk of nocturnal hypoglycemia. More people achieve HbA1c, more people are happy, mealtime flexibility is there, improved quality of life, cost effective treatment options, and also we have a good guidelines, scientific guidelines behind this molecule. So coming to the basal bolus, other insulin available there, you have a Tresiba, which is same thing I told you, insulin degludec. If you want to start a patient on basal regimen, this is the best insulin available, insulin degludec. And then we have a Fiasp, which is a fast-acting aspart. The Tresiba compared to other insulins is it has a flat time of action profile, no nocturnal peaks are there. It's a flat line for 24 hours, and you can see less hypoglycemias with this drug, and lower variability compared to Clargen, you can see, and total glucose lowering effect is more evenly distributed across 24 hours, and it doesn't peak at any time. It's a flat line like a basal insulin, and better time in range is achieved with this drug compared to other basal insulins, and overall low rates of hypoglycemia with Tresiba compared to other NPH insulins because there is no peak in the midnight. And wider dosing flexibility is available with Tresiba. And basal insulin coming to the Fiasp, see it's an ultra fast acting aspart. You can see whenever you want to have a prandial control, good prandial control, you can add a Fiasp to a basal insulin. The basal, if you want to control your sugars by basal bolus, this is the best thing. Have a Tresiba at baseline, and you add Fiasp to the major meals. That's the best option you can have with the elderly patients, with any patients who are fragile patients, any patients with, you can see you have a brittle diabetes in them. This is the best thing. And if you use Actrapid, which has half-life of 3 to 5 hours or 4 hours, you have a cumulative effect. You see, you take Actrapid at maybe 9 a.m. and you want to take it 1 p.m. and at 7 p.m. You have an overlap because the half-life is not less than 3 hours. So you can see that this delayed hypoglycemia may have in older insulins. This is not with the newer insulins. And convenient dosing is there with the flexibility with Fiasp is there because of it is short-acting insulin. Coming to the summary of the 3 insulins, greater HbA1c reduction with a newer generation of insulins, lower risk of overall nocturnal hypoglycemia and lesser glycemic variability, wider window of dosing and flexibility with improved quality of life. In summary, I want to conclude that, see, every time we want to go for newer insulins, newer technologies and newer adaptations in your diabetes management. Likewise, these newer insulins also have a greater role in control of diabetes. You choose a best patient. If the patient is affordable for insulin, these newer insulins will have a very good glycemic control and the patient will be very happy to use them. You have newer pens with no fan needles. They are very painless, absolutely 100% painless. Many patients say that they are very fine with these newer no pens also. So use of these drugs will make your patient's life better. Thank you.
Thank you, Dr. Rama Mohan, for providing your valuable insights. I wanted to ask you, Tresiba is approved in pregnancy, Fiasp is approved in pregnancy. However, the combination Rizodac is not yet approved. What are your thoughts?
Maybe, I think traditionally speaking, there is no rationale behind it. We need, maybe data is not there, that's the reason. If you have a data in that, if you are giving separately or mixing, nothing, no difference is there, I think so.
Any other questions for Dr. Rama Mohan? If there are no questions, I thank Dr. Rama Mohan for this wonderful talk. Thank you, sir.
Thank you, sir. Thank you.
Hands together to appreciate them. Thank you, speaker and chairperson. That was an excellent session elaborating on the advancements in insulin therapy and the potential newer formulations in clinical practice. Humbly request you to proceed to the selfie stand for a photograph with the memento.